So the objectives are to understand basic principles of pharmacokinetics and pharmacodynamics. How many of you have ever used those words? You will be able to after today. Integrate some really practical clinical pharmacy advice from me. My background is I'm a PharmD, which is a pharmacist with a more clinical background. And I have some advice that may help you just with daily care. And then also we're going to talk about the drug development process and how it's changed and what you're facing with your loved ones and how exciting it is to be at this point. Just like you heard from the speakers before, it's a great time. If we're going to be in this boat right now, now's a good time to be on the boat. I do not have any conflicts for this presentation. So I'm going to show you this lovely picture. These are my children. These are my children when they were 5 and 6 months, 5 years old and 6 months, Logan and Lily. And Logan, who's now 23, and Lily is 18. Logan will tell you they're actually here at the conference and they're going to be coming for lunch. She'll tell you that this picture represents the last normal vacation we had as a family. So I'm not only a scientist, I'm the mom of a child with Dravet syndrome, which is a pretty close cousin in a lot of ways to what you guys are facing with some of your children. Lily was born in 2004. I had a completely normal pregnancy. She was born at about 37 weeks, but it was only 5 days before a scheduled C-section. Uncomplicated delivery, great APGAR scores, which are the tests, that you get as soon as the baby's born and then 5 minutes later. And everything was okay. It seemed to be, except the day after she was born, I called my husband from the hospital and I said, something's wrong with her. And I said, I don't have a good feeling. And there was absolutely nothing wrong with her. He thought I had postpartum depression, called in our internist and everything. And I'm going to tell you what the internist, who's actually a good friend of mine, said to me. She said, I believe you. And she said that because mothers do have instincts. And it really proved to be true. When she was around 4 months, 4-month-old babies are kind of jerky, right? Anyway, I started noticing things like now that I know was basically clonus, ankle clonus, little beats like this in her feet. And I didn't really think anything of it because, she's so young. But at 5 months of age, she had what I now know was a non-convulsive status epilepticus. So she had what looked like an absent seizure with no movement, and it lasted for 37 minutes. And I thought, okay, well, this is a neurological event. I'm not an MD, I'm not a neurologist. Is it a stroke? What is it? And afterwards, she was completely fine. She was not sleepy. There was no post-ictal period. And so I took her to the emergency room, and by the time I got there, it was over. So, back to the crazy mom, maybe she has postpartum depression. She's really fussy over this child. And then soon after that, what I now know is that she started having very subtle bilateral myoclonic jerks in her legs. And most people didn't even notice them. I did because I was the one that held her a lot. And so I started noticing an association with those myoclonic jerks and her body temperature. Not necessarily a fever, but a really, really slight increase in temperature, like if you're swaddling or if you're holding a child or a baby, those would get more pronounced. So for lack of better terms, this non-convulsive episode that happened at 5 months old was termed a spell. And let's just see if it happens again. And, I was really kind of okay with that because nobody wants to really face things until you have to. But at 6 months, she had a focal, so one-sided hemiclonic seizure that kind of started in her arm, kind of like this, really, really shaky just a little bit, but then it spread. And so it was kind of a Jacksonian march. That's what it's called when it kind of spreads. And it was 2 days after immunizations, but it took 33 minutes for it to stop in an ambulance when she was given rectal diazepam. Back then, we only had Diastat to stop seizures. Her EEG and her MRI were normal, and I'm sorry, that is not what she was prescribed. She was prescribed daily phenobarbital and rectal diazepam because the seizure was so long, and her developmental milestones were met. Between age 6 and 12 months, things really started happening. She started having hundreds of daily myoclonics that were associated with this slight increase in temperature, or the onset, kind of like the prelude to an illness, not associated with a fever. But when she would get a lot of these myoclonics in her legs, I knew that she was going to have a cold or something like that. And then those clusters would end up increasing in intensity. And if they did, they would always lead to an episode of a generalized convulsive status epilepticus, or kind of this migrating one-sided seizure with this Jacksonian march. So she started having those other ones. She was tried with levetiracetam, which is known as Keppra, monotherapy when the phenobarbital was discontinued, and then she began topiramate and clonazepam, which is Topamax and Klonopin, at around age 10 months. By that time, we had been in the hospital so much that, she's a baby. She was a baby, very light skin, very fine veins, and there were times that we just couldn't get an IV established. So a surgeon of 40 years at Wake Forest Baptist Hospital came in and told me that she needed to have a portacath, because the next time might be the last that we, wouldn't be able to gain access. So she had a portacath placed at 10 months, and she ended up keeping that portacath because we maintained its patency and everything until she was 8 years old. So during this period of time, ER visits were followed by hospitalizations weekly or bi-weekly. And the triggers that she had were excitement. So anything that made her happy, she'd have a seizure. Loud noises, fever, illnesses, fatigue. But her developmental milestones were still being met. In fact, she was precocious. And then I had this chance meeting, actually, between the time she was 5 months old and 6 months old. We were at a legal conference for my husband, and I met a pediatric neurologist on the beach, and I told her about the spell and these little myoclonics. And she said, I just did a presentation, Grand Rounds presentation, on this really rare epilepsy. There are 500 cases in the world that's called severe myoclonic epilepsy of infancy. This is now known as Dravet syndrome. She goes, I'm really sure this doesn't apply to her, but I have the presentation if you need it. Here's my card. The very next day, when we got home, she'd been riding in a car. It was hot. We put her on a blanket in the kitchen, and she had this big, big old seizure, that wouldn't stop. And then once we got out of the hospital, I did contact this neurologist. Her name was Dr. Birch, and got the presentation, and I was devastated, because like many of you only had data for the absolute worst cases that you could read in articles and things in the very beginning. But over time, you have realized that what your kids have and what my child has definitely is a spectrum disorder. And there is no crystal ball, and there's no way for you to predict the outcome of your child. And I'm going to tell you, like we've discussed before, this is a great time in science to be here. This is just a little table. It's from an article that was published in 2015. I'm sure the the physicians and PhD researchers have seen this article, and it's really hard to see on the screen, but it's kind of just describing the different types of epileptic encephalopathies that begin in infancy and childhood. And you can see over here, this is the CHD2 encephalopathies, and the groups are, these are associated with other syndromes like Dose syndrome and LGS. And I understand that there actually are patients with LGS that have actually been diagnosed with this mutation that we're talking about today. And then, Dravet syndrome's right here. There's a lot of similarities. The myoclonic jerks, the myoclonic epilepsy, early on, there aren't very many syndromes that you see these myoclonic jerks. The mutation caused by the SCN1A, the SCN1A mutation is similar to the mutation for the CHD2 in that it is autosomal dominant. It's a haploinsufficiency. And most of the time it causes a loss of function of the protein. The difference is this is a very specific SCN1A mutation, is it actually makes sodium channels in the neurons defective. And when those are defective, the brain can't stop being excitable. So the influx of sodium into and out of those brain cells controls excitability in the brain. And so when you have a defect in that channel, it's like always too excited, right? And so it allows a little bit more targeted pharmacotherapy focus for this syndrome, because we know what we're targeting, but we also know that based on if this mutation is a loss of function, which it almost always is, then we probably shouldn't use potent drugs that are sodium channel blockers, because it's going to make the seizures worse. It's going to add to the excitation. And so, pretty much after this mutation was discovered, which I think was around like 2003 or something like that, and it was commercially available in 2006, which Lilly was one of the first people tested in the United States. So it kind of streamlines our pharmacotherapy a little bit. And that's another P word I want to tell you about. That's called pharmacogenomics. So when you can look at a disease-causing mutation and you see the genetic background of a person and you can curtail existing therapy, then that's awesome. But pharmacogenomics for you is going to be actual gene therapy, which is far better than the band-aids of pharmacologic drugs. So everybody knows probably the definition of epilepsy. Epilepsy is diagnosed after 2 unprovoked seizures. It's a very broad term. The seizures need to be at least 24 hours apart. But you know when you have epilepsy because you continue having seizures. The goal of any epilepsy treatment is to attain seizure freedom without adverse effects. Right. Okay, so most children with Dravet syndrome, and I think many of your children have what's called drug-resistant epilepsy, and that's when a person has failed to become and stay seizure-free with adequate trials of 2 appropriately chosen anti-seizure medicines that are tolerated by the person, that are tried alone or together with other seizure medicines. So I think talking about some basics of pharmacokinetics and pharmacodynamics will help you pretty much understand a lot about the pharmacology that that you're giving your children currently that hopefully will go away in the future. So basically, pharmacodynamics is what the drug does to the body, but pharmacokinetics is what the body does to the drug. And these are equally important. These 2 principles are the basis of any drug approval. Because to get FDA approved, a drug has to be safe and effective, right? So these are the principles we're looking at. So let's talk about pharmacokinetics first. As you're giving medications to yourself or your loved ones every day, we're going to talk about some principles that will allow you to understand why you should or should not do certain things, especially things that are in the advice from patient leaflets or from your pharmacist or doctors or practitioners, as well as those little labels that you see on the bottle. There are reasons for these. So the next slide has a good diagram that we're going to discuss this further. Okay, so what does the drug do to the body? How does a drug work? And we're going to focus on oral medications, which is the majority of medications that people take. Once you swallow the drug, it has to go somewhere. Where does it go to actually work? And how does it get there? It's because all drugs are targeted to certain receptors, which a receptor is actually a protein. Everything's protein, right? We hear it, protein. And the drug finds its way to wherever it needs to go to attach to the receptors there, right? And so we want to make sure that the drug actually gets there and stays there for as long as it needs to be effective. And that's how dosing forms are actually thought of and developed. So this involves a dose-response relationship, but not always. When dose-response relationship is very important in epilepsy, then you use labs, blood tests to determine like what your therapeutic level is, what your level is. Is it therapeutic based on prescribing information? And then you stay within that, you need to stay within that window. That was true for most older epilepsy drugs. Newer epilepsy drugs, there's really not so much of a dose effect associated with it. But when you have to have a drug within a certain level, that drug has what's called a narrow therapeutic index. And we still do give medications like this to our loved ones. And we're going to talk about why that is important. Okay, so this is my little diagram here of all the ADME, absorption, distribution, metabolism, and excretion. So you swallow the drug, and obviously it goes to the stomach. And it's really hard to get a drug formulated to be able to withstand all the acid, all the acidic liquid in the stomach. So that's key number one for oral drugs. But although it's in the stomach, most of drugs are actually absorbed in the small intestine. Why? Because there's much more volume, there's much more space. There's a lot less to fight once it gets into the small intestine. It's not a basic pH. The pH is like maybe 5 in the small intestine, but it's more likely to be absorbed there because that's where it stays the longest. And then there's metabolism, and everybody knows that drugs have to be metabolized to be excreted from the body. And most drugs are metabolized in the liver. There's only 6 different enzymes in the liver that a lot of seizure drugs, anti-seizure medications, are metabolized by. What do you think that means? Great potential for drug interactions, right? If you're giving drugs that are largely metabolized by the same mechanisms, and we're going to talk about that. And then it leaves the body either mostly in urine or feces. Okay, if you don't remember anything else, I think this is a really important slide to remember. So let's talk about how the drug's absorbed and distributed. And let's talk about what is the perfect way for drugs to be administered in the perfect world. That's with an IV infusion. So with an IV infusion, you start a drug and you continue giving the drug at the same rate as long as you want to. in perpetuity, right? Okay. So if you have a level to target, no problem. You just adjust the dose of the IV. But most drugs are oral. This is an oral drug that's given 4 times a day. So each time you give a drug during the ADME process, you're going to have absorption, and it's going to peak. And then you're going to have elimination and metabolism, and it's going to trough. There's a trough or a valley. If you have the desire to keep within the therapeutic levels you want with an oral drug that's given 4 times a day, look how hard that is. Because what you're going to want to do is for that peak to stay between here and here, right? And what happens if you give something, you know, more than once a day, and you have these peaks and valleys, and you forget to take a dose? You're going to go even further down in your trough, and you're going to be out of your therapeutic window. So even though drugs might not have therapeutic windows that you are monitoring labs for, the way a dose is recommended from all the clinical trials is based actually on phase 1, phase 2, and phase 3 research we're going to talk about. So the recommended dose is the dose that was approved to be most effective, right? So it may not directly correlate with a lab value, but the studies have shown that doses between X and X are the safest and most effective doses for the person with the indication it has. Does that make sense? Okay, what happens if you give a drug that's sustained release? So drugs are developed that are sustained release are developed to last and stay for a longer time in the small intestine. That's either through enteric coating, like a coating that kind of dissolves over a period of time, and or other ways. There are other ways to formulate drugs so that it'll last longer. So if you give, let's say you give a drug that you're going to have to give 2 times a day, or maybe even 1 time a day, you can see that this is, if you give it at the right time, let's say here's a sustained release drug, and then you go ahead and give it in time enough for it not to drop below therapeutic levels, you can see that it's closer to an infusion. All right, that's pretty much the gist of what I wanted to talk about. For people who take drugs that are a patch or something like that, that's actually also pretty close to an infusion. You don't take it on and off, right? So let's talk about how this can be really, really off based on certain drug interactions or physiologic interactions from the patient. So things that affect absorption are here. And we're going to talk about this in practical advice, like what we have control over in this area. And then after it's absorbed, you get this concentration that we just looked at the profiles, and then it distributes all over. And some drugs are affected by how much protein is actually in the blood. And so people who go on a ketogenic diet, or people who become malnourished for some reason, they're sick for a long time, and their albumin changes, and there's some ways that drugs can be displaced from protein binding, and it can either decrease efficacy or increase side effects. And so those are some things we need to think about. And then it's metabolized and excreted. And then this metabolism part, we're talking about either induction or inhibition of these enzymes. If an enzyme is induced, then the drug levels go up. That means the metabolism is faster. But if enzymes are inhibited, you can get really toxic. I mean, if they're inhibited, it actually can go either way. So you want to avoid drug interactions as much as possible. But, the problem is you have to rely on your practitioners to really follow this. I will say that, typically in the prescribing information that you can find online, it's not dispensed with your medications. You can get the prescribing information and look for drug interactions yourself if your pharmacist doesn't have time to talk to you about it when it's dispensed. But again, these drugs are a lot of times kind of riddled with drug interactions. So practically, these are the things that I think that we as parents can do on our side to kind of make this whole pharmacokinetic dynamic process as good as possible. So most oral medications are weak organic acids or bases that are non-ionized or unionized, which makes them lipid soluble. Why do drugs need to be lipid soluble? Because to get to where they're going, they have to cross membranes, right? And membranes love things to be lipophilic, fat loving to get across. So if you have a change in the pH of the GI tract, and depending on if you're full or fasted, and if you have delayed gastric emptying, then absorption can be altered. Some of the things that can change the pH in the GI tract, if you're not really heavily monitoring pH in the ketogenic diet, it can change the pH in the GI tract. There's certain, foods and beverages that that are acidic. Typically, everything's so short-lived that's in the stomach as far as digesting things. You're not going to have a big problem unless your kid just, drinks vinegar all day or, drinks something really acidic all day. But the full or fasted stomach is important because all the clinical trials that are done on pharmacologic drugs, beginning with healthy volunteers, we study what happens to the absorption if the patient's eating or not. So if it says take on an empty stomach or take on a full stomach, then you need to follow those directions because that is going to provide optimal absorption. And then delayed gastric emptying and kind of slow GI motility is common in people who have Dravet syndrome. Most people really have to be on medicines to prevent constipation. Some of the kids even end up with obstruction, and it's just because of low motor tone associated with it. I'm not sure about this syndrome, but just stay aware of constipation issues and talk to your doctor about those. Grapefruit juice actually inhibits one of the major liver enzymes. The grapefruit juice warning. You got to eat a lot of grapefruit and drink a lot of grapefruit juice for that to happen, but it is a possibility. So you see the grapefruit label, that's why. And then I guess the most important part is now that you understand pharmacokinetics and extended release versus that immediate release where you dose more often, if you see don't crush or chew, don't do it. Because it is going to change the absorption and you are going to have some effects from that. I know that some of you have children who have status epilepticus periodically. And, in cases like ours where we have drug-resistant epilepsies that we're dealing with, not only are we trying to minimize the daily seizures or the weekly seizures, we're trying to keep them out of the hospital and alive, right? So if you crush or allow chewing of these delayed release drugs, then it's going to cause a problem. And I've seen many times where families are trying to crush and put in applesauce and everything, and it ends up in an ER visit. And then a lot of people have asked me over these years, what exactly to do after there's like a vomiting and emesis. You ever thought about, have you faced that where your child is taking something and it's pretty close to the time that you actually administered the drugs, We don't have to worry about anything pretty much, period. I wouldn't redose if it's a suspension or a solution, okay? Unless it's 1 second or 5 minutes after the drug is given. But the simple thing is to always, I know this sounds really disgusting, but look at the emesis, and a lot of times you can see pills still in there. And also consider the frequency of administration. If you're giving a delayed release drug, most likely it's still going to be in the emesis because it's coated. And so you're going to know whether or not you need to redose it. If you're given an immediate release drug, it could have dissolved pretty quickly and it's harder to tell. So talk to your neurologist about, or your practitioner about what they would recommend in these situations, but also, you know, consider the severity of the epilepsy and the frequency of status epilepticus that occurs with a child. Somebody that's well controlled could do much better, just, okay, err on the side of caution, and we're just going to give the next dose. But someone who's prone to being in the hospital, you know, it might be okay to be sleepy for a day, you know, to prevent hospitalization. That's a conversation you need to have with your practitioner. Also, following the recommended storage conditions is very important. A lot of times you'll see medication that's in an amber colored bottle that's a liquid. It's there because it's light sensitive. And when the drug was being developed, stability studies were done by the pharmaceutical manufacturer to see what environment would be best. So if a drug's not stable, then it could lose potency or it could have impurities form in it. So if it's refrigerate, you say refrigerate, or, you know, do not expose to light, etc. The other thing is, oftentimes I have found I really wanted to pre-fill medication syringes because we have different caregivers for Lily. It's dangerous to do that unless you really know about the stability information of pre-filled syringes, and that's hard to find. Pharmacists can look it up through a pharmacist website to see if any studies have been done. And if all else fails, can call the manufacturer. And actually you can call the manufacturer if you have questions about stability in any studies that have been done, pre-filling medications, etc. It's equally important to understand that transferring medicines from a glass bottle, let's say a drug is dispensed in a glass bottle, but you decide you want to put it in a plastic bottle, there probably is a reason that it's in the glass bottle based on its stability, because the bottle that's used can actually affect stability. So I never recommend transferring from a glass to a plastic bottle because most likely it's going to affect stability. How many of you have ever used orally disintegrating like clonazepam or Klonopin? You know, it's in that foil pack. It's in there because if it's taken out, then and it's exposed to humidity, it's going to disintegrate. So it should stay in the foil pack. And so if anything's in a foil pack, almost anything, iron tablets are often dispensed in a foil pack, not because they're going to disintegrate, but so children won't think they're candy and eat a bunch of iron tablets and get iron toxicity. So sometimes it's to protect children, but most of the time there's a reason to keep it in the foil pack. I do a big pre-filled med tray. I do that because I know if the drug's given, period, because believe it or not, you can forget to give drugs. And also I fill it and I know that it's right, okay? There are pros and cons of doing that. The pro is what I just said. The con is if you do misfill it, most likely they're going to get the wrong meds for several days, like a week, right? So that is a very individual decision. My child takes 17 different medications. not all seizure medications, but I just feel better about it, but it's something to think about. So a lot of times I'm asked, should we do brand name only drugs? Have you ever thought about that? This is the clinical answer, the scientific answer. When a drug is developed for the market and is the brand name, then that is the standard that the drug should be replicated by for generics. However, no studies are done, no clinical studies need to be done for generic drugs to come into market, only pharmacokinetic studies. So, and typically those pharmacokinetic studies are in healthy volunteers, not the patients. And it's to show that the bioavailability is similar to the brand. There could be a plus or minus 20% margin for generic drugs. So if you switch from a brand to a generic because you have to, and sometimes insurance companies are forcing us to do that, then you have to. And you can actually probably not determine how close that drug is pharmacokinetically to the brand. But what you can do is monitor after the switch, see if there's any more seizures, see if the side effects worsen. And then, with your clinician, go ahead and discuss how to make that better. But you can ask the pharmacy to only dispense that same generic going forward. Because as different brand name generics come out, there's still a plus or minus 20% bioavailability compared to the original brand product. But that might be very different than the first generic drug or the second generic drug. And if you have really, really drug resistant, very fragile epilepsy, this is important. So those are conversations you might think about in the future. Be cautious and always discuss natural supplements with your neurologist. And I'm going to have a couple of slides to go through those. Natural supplements doesn't mean that they're not potentially problematic. In the United States, natural supplements are not regulated by the FDA at all. You can have a product that you ingest that may not have the active ingredient in it at all. There is no regulation. So essentially, you don't know really what you're taking. I think that's a big problem here. I'm not discouraging the use of natural supplements. A lot of people really rely on them, and a lot of people consider them effective. But there's also no clinical proof, real clinical proof, that are rigorous enough to determine that the drug's efficacious or the supplement is efficacious, and the risk benefit that the FDA uses to approve a drug is not evaluated. Having a few patients published just to say that garlic helps seizures or whatever other drugs isn't enough data to not have a bias against it. That's why we do well-controlled clinical trials. And we'll talk about some more. How many of you have a sick plan for your child? So a sick plan is a plan that you develop with your practitioner if your child always has worse seizures during an illness. That plan may be to increase the dose of one of the anti-seizure meds. That plan may be to do a bridge with another medication during the illness. Anybody do that? Okay. Yeah, and that actually is very useful if you're in the hospital a lot to prevent hospitalizations again. I learned all this stuff on my own, by the way. Okay. If the seizures are prolonged, how many of you have a seizure action plan? Okay. And then I found that, have you ever tried blue polarized or cross polarized sunglasses for photosensitive seizures and pattern stimulation? Okay, this is a list of supplements that may increase seizure activity. Are these slides going to be available? Yeah, the slides can be available for you guys. And these are OTC and prescription medications that may cause or worsen seizures. Benadryl, especially given often or in high doses, can lower the seizure threshold and cause seizures. Sudafed, any type of stimulant type product, like phenylephrine, dextromethorphan that's in cough syrup, especially if you give it kind of routinely for several days. I don't know who would give their child energy drinks, but no judgment if you do. But, probably don't do that. Prescription drugs like oral contraceptives can either increase or decrease the effects of anti-seizure meds, and some anti-seizure meds can actually decrease the efficacy of birth control. There's one antidepressant called bupropion or Wellbutrin that's associated with seizures. Pain medicine tramadol, if your child ever has surgery, sometimes that causes seizures. And then certain high dose antibiotics. So if you're ever in a hospital on an IV antibiotic, watch for that. So I'm going to continue with Lily's journey, and I'm not going to belabor it. The one thing I wanted to let you know is that before what we use now, which is called an expanded access program, there was a way to import drugs that were not FDA approved, and it's still there, but it's kind of frowned on. And this is a website that you can read information about that. So if all else has failed, all FDA approved drugs, there's ways to import it through the FDA, this provision. I do want to let you know that around this time in 2007 was the inaugural Dravet Syndrome Conference. It had a big impact on Lily's journey, how I parented both my children and my professional choices. We're going to go over, a couple of things with clinical trials. The FDA Orphan Drug Act was passed during the Reagan administration in 1983. And a woman who had 2 children with Tourette syndrome, it was the spark that caused this to happen. And this act allows drugs that are being developed for rare diseases, which is defined in the United States as less than 200,000 prevalence, to get certain funding, longer period of exclusivity, et cetera. And then through the last few years, there's been several accelerated approval pathways. And after I had been in the nonprofit kind of volunteer world for Dravet syndrome, I decided that what I wanted to do with my career, previously I was with Big Pharma as a scientist, is to focus on drug development. And I started my company in 2008. And I've helped pharmaceutical manufacturers from across the world get drugs through the FDA process for rare diseases. A couple of the drugs that I've worked on here, my big one was Epidiolex, cannabidiol. And I have done a lot of expanded access programs at different universities with different physicians and through companies. Expanded access is a way for, if a drug is being researched, it can be made available to patients prior to FDA approval in certain very critical conditions. There's a website for that too. So preclinical research occurs when, like now for you guys, all this genetic stuff, all this preclinical research has happened over time. And that gives the pharmaceutical companies an idea of, is this drug, does it have potential to work, right? And a lot of times it gives you a chance to understand the biomarkers that was talked about before. Biomarkers or surrogate markers are clinical markers to show that a disease may be corrected, or the drug may work based on a certain thing. So like, you know, biomarker for CHD2 could be, I don't know, being able to measure CHD2 levels, which probably would have to be in the brain, that might not be, but it also could be this methylation that we were talked about before. There are other things. It could be an EEG, like that was mentioned before. It could be clinical symptoms, but it's important if you can have a biomarker and be an orphan condition. In phase 1 studies, those are the ways that the pharmaceutical companies assess the pharmacokinetics and pharmacodynamics of the drug in healthy volunteers. There's typically one phase 1 study. A phase 2 study actually is with patients, and a placebo is typically introduced in this group. Several hundred patients, and it could last several months to a couple of years. You can see this is a long process. And you can see that only 33% of phase 2 studies move into a phase 3. And so currently in the United States, 2 phase 3 clinical trials are necessary to get the drug approved. That could be different. You know, part of my job is to help negotiate these type of these requirements from FDA based on the condition, right? Based on the orphan condition, is there any therapy, et cetera. After the last phase 3 study is completed and the results are tallied, a new drug application can be requested to the FDA, and it can be approved or not. And then a phase 4 study is required just to further study long-term safety and efficacy. And about, I'd say more like 70% of the phase 3 studies end up going to phase 4. A lot of drugs that I've worked with just die. Lack of investment, lack of results, et cetera. And you've talked about some benefits of working with clinical trials. The bottom line is, in this particular study, 98% of volunteers would consider participating again in a clinical trial, particularly if there's no other drug therapies available for the patient or for themselves. This is a link to the Expanded Access Program. And clinicaltrials.gov has already been mentioned as a resource, but if you ever heard of PubMed, instead of Googling research and stuff, you can just go to this website, and this is all published data regarding whatever your question is. And it takes you right to the published data. That was a lot to cover in 40 minutes. We'll go to questions later. I really appreciate your attention. And I want to say to you that I was not in a good state of mind the first meeting that I went to. I was actually one of the speakers and stuff, and it was very hard. In hindsight, I just realized how much it gave to me as a parent and how much it helped Lily. And always remember that there's no crystal ball and that no person's going to end up the same. And you all have your own journeys. And actually, my journey with Lily has been a joy.